probably the oldest person in the room. Who's been doing ITP, man and boy. And he's going to review ITP, what's changed over the last 200 years, and he's been around for most of them. Thank you, David.
Thank you, Daniel. It's always so fun to be with you because we share a common sense of joy. But anyhow, nice to see everybody. It's nice to see so many familiar faces. Adrian asked me to talk about the last 20 years. I'm going to start with the last 200 years. And these are my disclosures. I work with many groups to develop therapies for ITP. I'm going to guide you through something that Dr. Semple and I have done with the American group to talk about ITP for the last 400 years. And we'll start briefly from here, and we'll get over here if we got the time to tell you what's happened in ITP, and also bring you up, this is a historical talk, but also tell you how this brings us to modern times with newer therapies. So we're going to start in the far left with the older guys here, much older than Dr. Newland is and myself. These are the folks who did a lot of the seminal work, and we'll start with the British guy, which is Robert Willan, who in 1908, this is this very dour-looking Yorkshireman, published his monograph, a copy which I have in my office at home, and it's called On Cutaneous Diseases. And he described these things which many of you know, which are petechiae. This is called purpura simplex here. I think you all know these bruises, which he called purpura hemorrhagica. And then he starts telling us about ITP and describes the most modern therapy in 1808, which was, he says that purpura hemorrhagica occurs at every period of life, and it chiefly affects persons of a weak and delicate habit. Hear the next phrase: women and boys appear to be most liable to it. In the latter, the hemorrhage usually takes place from the nose. He then wanted to say what causes ITP, which is a sedentary mode of life, poor diet, impure air, and anxiety of mind. These are the usual exciting causes of the disease. And he is the first guy who tells us how to treat ITP. He says, in the treatment of this disease, we should recommend moderate exercise in the open air, a generous diet, and the free use of wine. So I understand it's going to be provided in the break. Is that true? No. Without air, exercise, and an easy state of mind, the effect of medicines is unclear. And I will simply say right now, in this statement here, I will tell you that the effect of many medicines these days, particularly in ITP, is rather clear. So we skip from from 1808 to some other folks here. These are people, Wright and Duke, who talked about the first therapies for ITP. And I will simply say that this other dour-looking Bostonian, which is James Homer White, in this lovely lab, it's like out of Frankenstein right here. And this lab still exists at our hospital, by the way. I don't use it, but it's used for administrative offices. And he described for the first time for real that a blood cell called the platelet. Here's the platelet here, a big one, like many of you with ITP haven't heard red cells here. This is probably a more normal sized platelet up here. He described platelets as things in the blood that cause you to clot or not clot, as the case might be. And then he went on to describe the origin of these things called platelets, which he called plates. So this is the 1906 paper he published on this disorder. And he described the fact that platelets come from our bone marrow, from a cell down here called remember what the name of the cell is? Megakaryocyte. And this is shedding into the bloodstream these small particles, which are the platelets. So he was the first guy who described where platelets came from, and that if you had a low platelet count, you bled. And then across the hallway from him at our hospital, and this is now in 1910, this guy named William Duke published an interesting monograph of using the first therapy for ITP, which was platelets. And he was the first chap who actually did a real platelet transfusion, and he did it in a rather interesting way that I probably think none of you would ever admit to these days. Here's a patient right here with a low platelet count. This patient is then hooked up to another patient with a cannula from patient A from donor to recipient, and the blood goes from the donor to recipient. The platelet count rises, and then it drops off as the transfusion abates, but the bleeding tended to disappear. So the bleeding was high here, dropped with the transfusion, and then returns as the platelet count becomes lower again. This is a platelet transfusion for the first time that was well documented. Maybe some of you had these things. So we go from 1910, and there's a rather long list of things happening here. But the next therapy for ITP is these guys right here. And one of them, a guy named Paul Kasnelson, whose picture is shown here, describes the therapy that some of you might have had called a splenectomy. Anyone know what a splenectomy is? So I'm just, sorry, Caroline, I know you know this, but yeah, so this is rather dour. Everyone looks dour. I mean, they're not jovial folks like Dr. Newland and Dr. Provin. I mean, these are all very grim faced, but this is Paul Castleton. He actually encouraged his boss to take the spleen out of a young patient whose platelet count went from 2,000 to 500,000. What he didn't comment upon is the next two patients didn't respond terribly well, which is sort of a useless statistics in treating ITP with splenectomy. But this is the history of the second therapy, transfusions number one, splenectomy number two, and ITP. And as you all know, the rate of splenectomy has dropped enormously. This is the modern update. So I'm going to use some history to bring you up to date on these things. But the use of splenectomy has rapidly dropped off. This is 2009, and if I could extrapolate, it's probably down here right now. Maybe Fred can tell us the exact numbers from the registry a little later on. But again, this is the next therapy for ITP, platelet transfusions, taking your spleen out. Then we skip a few more years. We go to 1951, and this comes back to the guys who sort of told you what ITP was. And this is our friend, Dr. Harrington, and Dr. Semple and I love to show this slide. He took blood or plasma from an ITP patient and infused it into himself, and his platelet count dropped to a low level here. He almost died. He had bleeding, and then his platelet count came back, and other members of his laboratory had the similar experiment. But this is how you did experimentations back in the 1950s. And this demonstrated that, you know, there was something in the blood of ITP patients that made you have ITP. And then this leads to our third therapy. About 1965 or so, 1958 or so, we have the appearance of corticosteroids. Anyone know what corticosteroids are? Sorry, I'm joking here. So basically, this is when the precursors of prednisone and prednisolone came. This is a patient with a low platelet count here. Is given some prednisone, platelet count rises, prednisone stop, platelet count falls, and you guys know the rest of the story. But this is the third therapy of ITP, and this is the basis from 1950s when this was done. And there are many other experiments. And as you probably know, if you've had corticosteroids for ITP, you know, about 70% of patients respond to this. The response only lasts in maybe a third of all patients up front with corticosteroids. Then we get to the interesting thing down here. The doctors assess adverse events from steroids as being 23 to 56% in clinical trials. And then if we ask the patients, and you're all here, everyone's got side effects. So this is a therapy you're all familiar with. And the current use of corticosteroids, as we will talk a bit more about, is for a very short period of time in your history, probably no more than 2 months at the most, being on corticosteroids at a significant dose for ITP. And this is probably the other update in ITP that we all particularly agree with right now. Going back to ITP in terms of its initial therapy, we still use corticosteroids a lot, but there's a huge effort afoot to use other agents up front. I'm just listing a whole bunch of things such as rituximab, a TP receptor agonist, mycophenolate. There's a whole bunch of drugs being tested as early therapies for ITP. Maybe if we treat more aggressively up front, there'll be a better outcome and people won't have chronic disease. But that's the other update in terms of what's happening in ITP. More upfront therapy might benefit patients from not becoming chronic. So we shift gears a bit. We then go a little later on and we go to the 1960s here, and we have Dr. Schulman's lab, and he showed that the stuff that was in the Harrington plasma that caused ITP was an antibody. Everybody know what antibodies are? So we're in the COVID era right now, so you all know that if there's the COVID virus, we make antibodies against the spike proteins. Well, it's been shown that in ITP patients, we have similar antibodies that attack the similar spike proteins on the platelet. And so this was the publication by him back in the 1960s showing that the factor in ITP plasma is an IgG. And this is leading to a whole bunch of other therapies, some of which you're familiar with and some not yet, to treat ITP. And I'm going to just take you through the therapies that emanate from this discovery that antibodies are a major culprit of ITP. And this is a list of things you all know that are used to treat ITP: splenectomy, corticosteroids, rituximab, this stuff called IVIG. And there's a whole list of things right now being developed. These are molecules. I won't give you the crazy names. They got names like megazitabgamab or bortezomib. These are things that try to make your antibody production much less. I'm going to mention two things that you might have heard about recently. One is called a neonatal Fc receptor inhibitor. And I'll talk to you about a nifty other new drug that's being developed to make the antibodies disappear. So the focus of all of the therapies on this list is to make the antibody causing ITP to disappear. And there are two things I'll briefly talk to you about. Every day, we are all ingesting half of our plasma, which is a liquid part of our blood, into a cell that lines the blood vessels called the endothelial cells, and we're processing that. So what happens every day is you suck a little bit of plasma into this little vesicle right here, and then proteins in the plasma are just degraded, but the antibodies, which are shown here in green, are protected by this receptor, and then they recycle the antibody to the surface. Now, if you have ITP, it's these antibodies that are causing you troubles. So is there a way to make these antibodies become less? And the answer is yeah. There are some new drugs being developed that actually are an antibody drug, but it binds to this thing called the receptor in blue, and your bad antibodies, which are in blue here, then get degraded and your antibody levels drop. And many of us have participated in a study recently with a drug that does this, and we can drop your antibodies in total by about 40 to 50% shown here. And in patients who receive this form of therapy called efgartigimod, the platelet count rose in about 35% of patients. So this is one therapy direction going on right now, is to make the antibody that's physically causing the ITP to become less. Now, this is the platelet count rise in these patients. It wasn't terrific, but about a third of all patients had a rise. Now, I said a minute ago that we have antibodies that are making ITP. This is the structure of the antibody. And I'm going to use a term called the FC portion in a minute here. I'll come back to this in a few minutes, but this is an antibody. And what's interesting about antibodies is there are bacteria that chew up antibodies. And you can actually make this substance from bacteria, and you can give it to patients, and it cleaves the antibody completely away, and the antibodies disappear. And this is a drug which has been used, and it can make your antibodies go from here to 0 in 8 hours. This is a pretty neat way potentially to make all immune disorders get better, particularly ITP. The problem with this drug is that once you give it, you can't give it a second time because it's a bacterial product and you make antibodies against it. Well, what's neat about artificial intelligence is it lets you do some constructive stuff. And we are working with 2 companies in the United States to make an antibody, which instead of, it persists. And this is, we use AI-guided remodeling. You can make a new destroying enzyme for antibodies. And we're going to be using this in a whole bunch of trials very shortly to make antibodies acutely disappear. It may not be a permanent fix for ITP, but it may allow us to get control of the disease rapidly in any situation. So let's go a bit further down the stream here. We're going to make it on time, I think. We then get to another group of authors here. This Newland guy, I don't know how he got snuck up there, but this is, he should be way back here, but he's actually here. So in the 1980s, and this is the first use of IVIG. And basically IVIG, this is old studies where you give IVIG and the platelet count rises very nicely. And this showed that IVIG was an effective therapy. Now, the problem with IVIG is, and Adrian can comment, is we don't actually know entirely how it works. There are many mechanisms. And this is a list of things that we're now looking at. So IVIG does one thing, but you can play with IVIG and make it into a super IVIG. It turns out only about 5% of the IVIG actually works in ITP. And that's the thing called silent IVIG. And you can make more of this and create a super potent IVIG. But what's important is that I mentioned there's a bottom half of the antibody molecule called the FC portion. You can play with this in a test tube. And what's been played around is you can make different constructs. Here's one single, what's called FC portion. You can make a doublet or triplet here, a pentamer here. This molecule is highly potent. This molecule will turn off the cells in your body that chew up platelets. And what I'll show you here is an animal model. It's like the stuff that Dr. Semple does. We take an animal, give them ITP, give them IVIG, but give them this new substance, and the platelet count returns to normal. So this is a nifty new therapy to make the ITP disappear. This is under development right now. It's a new therapy for making making the IVIG into a super IVIG. So going further along, we have the discovery of a molecule called thrombopoietin back in 1994. And to show you a picture of what this means, this is a Wall Street Journal thing that says 2 companies claim victory, 5 groups claim victory at about the same time. And basically, to tell you what thrombopoietin does, many of you have used a thrombopoietin receptor agonist, TPRA. Here's a bone marrow culture without thrombopoietin. Here's a bone marrow culture with all these big cells called megakaryocytes. And this is what the drug does in all of you taking these agents. It makes your megakaryocytes big, humongous and very healthy. We then come to the next innovation, ITP, which is 2001 with our late dear colleague, Roberto Stasi. He and colleagues used the rituximab molecule for the first time, and they basically showed that if you give rituximab, platelet counts nicely rose here. And so this is a common therapy many of you have had. This therapy is used still a lot right now. It's not the cure for ITP we once thought it to be, and indeed, if you look at patients with rituximab, about 60% show initial response, 40% at 1 year, and 21% by 5 years. So it's still a good therapy, but it wasn't the cure we thought it might be for ITP back in 2001. Shifting gears, we're getting more modern, and people who did this work now still have hair on their heads, and it's not white. Well, maybe not all of them. We have the introduction of molecules that are based upon thrombopotence. This is 1994. And now it's 14 years later, we have recombinant molecules and others that stimulate megakaryocytes. You may know these by rimiplostim, L-trombopeg were approved here. Avatrombopeg, the third molecule, was approved in 2019. And these all have terrific attributes. These are called thrombopoietin receptor agonists, TPRAs. They include rimiplostim, L-trombopeg, avatrombopeg. There's a new one in China called heterotrombopeg, and one that's not being used in ITP called lusotrombopeg. There are about 4 or 5 others being developed. One of these days will bring the prices down, but that's a different discussion for some other speaker, some other time. The TPRAs, I'm going to not summarize. I'm not going to read this whole slide to you, but they have huge efficacy. The response rates are like 90% in new patients. The response is not lost, and most patients who are on these drugs have a terrific rise in platelet count. The good news is that, that maybe half of the patients, if you stop the drug after a year or so, the disease goes into remission, which is a novelty that we only now uncovering in with these agents. But many people on TPRAs, it's not for life, it's for a shorter period of time with good response rates. The flip side of any drug is, does it cause side effects? We've had patients out. I've got a patient out for 15 years on this class of drugs with no major issues, and they were highly effective for a long period of time. So we're getting at the home stretch here. We're going to make it, I think, Adrian, in terms of our time. I get to 2018. One of our dear colleagues, Dr. Bucell, working with others in this room, looked at another class of drugs called Syk kinase inhibitors. The one that we use is called fostamatinib. And what they do, this is our cartoon again, this is now a thing in your body called a macrophage. It's eating up your platelets. This is a chewing up macrophage. Megakaryocytes make platelets, macrophages destroy them. This is a macrophage eating this platelet. And if I can draw you a brief cartoon of what's happening in many of you right now, is that here's the surface of your macrophage right here. Here are your normal platelets in blue. Antibodies come along. They bind to your platelets. They then bind to the surface of the macrophage and are chewed up. And this is fostamatinib affects this particular substance here called Syk kinase and turns it off and prevents this from occurring. So this is another innovative therapy for ITP. So we have drugs now that attack this molecule, and we will soon have drugs that attack this molecule, both of which are necessary for these cells to chew up your platelets and cause ITP. Fostamatinib has a modest response rate of, say, between 18 and 43%. And those who take it, it's got some side effects of diarrhea and hypertension, but it's an effective drug in many patients. So we get to another innovation, which is 2019. And here are some of the authors still have hair on their heads that did this. This is Dr. Prove and others have international guidelines. What the guidelines have said, and this is important to take home, this is where the change in ITP over the last 200 years has occurred. You can often avoid therapy for platelet counts over 20,000, you're not bleeding. You avoid the use of corticosteroids for more than 8 weeks, and we can use larger doses as a rescue. We have the early introduction of the TPRAs and rituximab in ITP patients, usually at month 2 or soon thereafter. We try to avoid splenectomy for the first year, maybe forever. If medically, we can control your ITP. The goal is avoidance of bleeding, not a specific platelet count. So many of you may be totally happy at a platelet count of 18,000, others at 180,000. And we don't usually admit patients to hospital for a low platelet count because we want to protect you from the doctors who would otherwise do more aggressive therapy that's unnecessary. Oh, that has happened to others? At our hospital, you come in with ITP, you get steroids for no more than 2 months. If we haven't controlled your disease, we then put you on a TPRA. This takes care of about 90% of patients. If this doesn't work, we switch you to different TPRA, give you rituximab or give you fostamatinib, and about 95% of patients are fixed here. If this doesn't work, we add mycophenolate or low dose of prednisone, and you're at the 2.5% of patients where this doesn't respond. We go to a clinical trial. But this is the current algorithm in our hospital for treating ITP. It doesn't apply to the rest of the world, but I'm just saying this is how I would recommend therapy for ITP to be done. So finally, I'm just going to say that there are a lot of new agents being developed, and I'm going to just flash the last 3 slides. This is show you what's in the pipeline. There are a lot of drugs being developed to either treat ITP, potentially to cure ITP. They have many names. I'm not going to go through the names. This is list 1, this is list 2, and here's list 3. So there's a lot of stuff that's being addressed in this disease right now. Hopefully, in the coming years, we're going to be able to cure people with ITP. So to summarize, understanding ITP is progressing and it guides our therapy. A normal life is available for almost all patients. Newer medications are increasingly effective, unlike those that were described in 1808. Many have very few side effects. Treatment-free remissions are possible for probably half of all patients with ITP, maybe more. Many novel therapies are being developed. Our current goal is not just to raise the platelet count, but to create a treatment-free remission and minimize side effects of medications. The major problem to new therapies is access to these medications and costs. Thank you.
Thank you, David. That's a really excellent, succinct summary of what's been going on and an exciting view into what's likely to be available in the future. ITP is actually a very exciting disease, not for patients, but for the companies, because when you give it, if it works, the platelet count goes up. So you know very quickly if you've got something that's going to work. So a lot of these new agents are tried in ITP very early on, which I think is good for us as ITP researchers and clinicians. I think we've got 1 or 2 minutes to ask questions for David before we go to the breakout sessions. So if anyone's got any burning questions, although many of them can be dealt with during the later sessions, there's a hand up at the back.
Anti-HCT. I don't think I need that. I'm such a big man. My daughter, who's 21, she's at UCL as a student. She had ITP, she had treatment for that. But what has come up is that she's now being investigated for PV because her bone marrow is producing red cells. Have you got any thoughts whether it's chicken and egg or egg and chicken?
Well, I don't think the two diseases are related, at least from what you told me, but we have several patients who also have had ITP or have ITP and also have a JAK2 mutation causing either polycythemia vera or the other myeloproliferative disease. So there are 2 diseases, ITP, which is immune, and the myeloproliferative disease, polycythemia vera, which your daughter most likely has due to mutations. They're totally unrelated in my mind. It's lightning striking twice. Well, it's the good luck is both diseases are pretty easy to take care of. From the what's their platelet count? Yeah. We can talk more. I'm not convinced I know exactly why she's bleeding with those good blood counts. Yeah, no, happy to. I think the explanations may put the rest of the audience to sleep.
Hi, you mentioned the treatment that's being developed at the moment with the bacteria where it sort of eats up. How long do you think something like that would come to be available to us?
I think right now the studies haven't even started in humans. We're doing these studies in animals right now. So I think the good news, well, actually, let me take it back. This molecule is approved by the European agencies for treating one specific condition, which is patients being prepared for transplant. The current medication can be given once, but not a second time, and only works for 4 days. So it's sort of like a genie that it all disappears. But this molecule, once developed, will probably be an effective way to get control of the disease initially. It may not be a long-term therapy. And maybe a way to say, hey, platelet count 0, patients bleeding, let's get the antibody out of the system while other drugs have a chance to work.
Okay, time for one more question. Any more questions?
There's a,
Lady up there.
Your bullet point about 50% treatment-free remission, are there any trends as to which 50%, any common factors?
I wish there were. I think right now my major statement on my patients is most of you will be on a modest dose of some medication for a long period of time or be off it in 2 years. And it's about half the patients have the latter goal and the other half are still stuck on some kind of therapy. But again, most therapies these days, in my opinion, are pretty well tolerated with minimal or no side effects.
Okay, thanks very much. Thank you, David. Right. We've now got the